Bacterial meningitis. It's a true medical emergency where every single second counts. So today, we're diving deep into the critical pharmacotherapy that you, as a pharmacist, absolutely need to know to make a life-saving difference.
All right, let's kick things off with the single most important number you need to burn into your memory. For every single hour that antibiotic therapy is delayed, the risk of death or permanent disability jumps by 30%. That one fact right there drives the urgency behind everything we're about to cover. So here's our game plan. We'll start with what bacterial meningitis actually is, then we'll identify the key pathogens, we'll review our antibiotic arsenal, talk about adjunctive therapy, and finally, we'll look at the huge role pharmacists play in prevention.
Okay, first things first. We need to understand the battlefield, and that's the central nervous system. And I want to be clear, this isn't just about killing bacteria. It's about getting a catastrophic inflammatory response under control before it's too late.
You see, when we say meningitis, we're talking about this intense inflammation. It's triggered by bacteria multiplying in the cerebrospinal fluid, and it's that inflammation that causes the devastating and often permanent neurological damage we're racing to prevent.
So how does this all start? Well, the path of invasion often begins somewhere you might not expect, the respiratory tract. You get these common bacteria colonizing the area, they break through into the bloodstream, and from there they manage to cross into the CNS, unleashing that just devastating flood of inflammatory cytokines. Okay, so if that's how the invasion happens, the next critical question is, who are the likely invaders? Because answering that is the absolute key to picking the right empiric antibiotic right from the get-go. And the answer to that question? Well, it really hangs on two key factors, the patient's age and their immune status. This is the very first filter we have to apply when we're thinking about therapy. So for most children and adults, we're targeting pneumoniae and meningitis. But look at that crucial outlier, Listeria monocytogenes. It becomes a primary target in the very young, the elderly, and the immunocompromised. And that one single pathogen will completely change our initial drug selection. This is the classic presentation. When a patient shows up with this combination, alarm bells should be going off for everyone. It signals a major medical emergency where we have to act, and we have to act fast. And this quote right here highlights the absolute #1 priority. Treatment cannot wait for a definitive diagnosis. If a lumbar puncture is delayed for any reason, say they're waiting on a CT scan, the antibiotics have to be started based on clinical suspicion alone. Remember that mantra, time is brain. All right, this brings us to the core of our role as pharmacists in this emergency, selecting the right drug at the right dose and making sure it's given at the right time. So let's break down the go-to regimens that you're going to be verifying and dispensing from the emergency department. These are tailored to the most likely pathogens in these different patient groups. Understanding the why here is so important. You'll notice we lean towards cefotaxime over ceftriaxone in neonates. Ampicillin is added specifically to cover listeria in those very young patients and in our at-risk adults. And of course, vancomycin gives us that crucial coverage for potential drug-resistant S. pneumoniae. Now, when it comes to vancomycin, your expertise is absolutely critical. Proper dosing, administration, and monitoring, that's what stands between efficacy and toxicity in this incredibly high-stakes situation. Educating the nursing staff and the physicians that the flushing syndrome is a rate-related infusion reaction and not a true allergy. That's a huge pharmacist intervention. It prevents patients from getting mislabeled with a penicillin or beta-lactam allergy for the rest of their lives. Now, once those culture results and sensitivities are back, it's time for some good old-fashioned antimicrobial stewardship. Therapy can and absolutely should be de-escalated. For a penicillin-susceptible S. pneumoniae, we can narrow that coverage all the way down from broad-spectrum agents to a targeted drug like penicillin G. So, getting rid of the bacteria is only part of the battle. Now let's look at two other critical areas. First, how we manage the dangerous inflammation that infection causes, and second, how we stop this from happening in the first place. This brings us to dexamethasone. Now, this is a powerful tool we use to quiet down that inflammatory response, but its use is very, very specific, and the timing is everything. The key pharmacist intervention here is really twofold. First, you have to make sure dexamethasone is given before or with that first antibiotic dose to get the maximal benefit. And second, you need to advocate for its immediate discontinuation if the cultures come back with a pathogen where it's not helpful, or could even be harmful, like with listeria. Our role as pharmacists extends way beyond the hospital walls.
We are frontline defenders through vaccination and through making sure that post-exposure prophylaxis for close contacts is done right.
The dramatic drop in the incidence of bacterial meningitis is truly one of public health's greatest success stories. And it's a direct result of robust immunization programs against these three major bacterial pathogens. And when a case of meningococcal meningitis is identified, your role in dispensing PEP is so important. This is where that classic high-impact counseling point comes in, reminding close contacts that rifampin will turn their body fluids, like urine and tears, a harmless orange-red color. That simple piece of advice prevents panic and makes sure they stick with the treatment.
Okay, let's wrap this up and summarize the most important action points. These are the things you want to have locked in for your next shift. These 4 points right here, this is your foundation. Mastering them allows you to effectively and safely co-manage a patient with suspected bacterial meningitis and really contribute to a much better outcome. And this brings us to our final question, the one that probably keeps infectious disease experts up at night. As we face new pathogens and growing resistance, how will our antibiotic arsenal and our strategies need to evolve to keep fighting this devastating disease? Thanks for watching.